The chapter on thyroid medications was a lot of information in not very many pages, so I'm going to try to do it justice here as I try to really pare it down to, again, the main ideas and principles of the chapter. You'll notice that the focus is more on hypothyroidism, as I think that's something you're more likely to see in primary practice, but we'll touch very briefly on hyperthyroidism as well, just in so much as I'd like you to be able to recognize maybe some of the medications that are used and some of the, disease states that are associated with hyperthyroidism. Thyroid hormones exert their effects on nearly every system of the body. They have a multitude of mechanisms by which they create their effects. They regulate basal metabolism via a complex coordination of the hypothalamic pituitary thyroid feedback system. So T4 and T3, which are the active thyroid components in our body, are released by the thyroid gland in response to circulating thyroid stimulating hormone. Thyroid stimulating hormone comes from the pituitary gland, and the extent to which it is excreted is dependent on the thyroid regulating hormone, which comes from the hypothalamus. So when T3 and T4 levels rise, they feed back to let the thyroid releasing hormone and the thyroid stimulating hormone know, we got it, guys, there's enough of us around. And then obviously when those levels fall, the thyroid stimulating hormone and the thyroid releasing hormone levels will amp up to stimulate more secretion of T3 and T4. From a laboratory or monitoring sense, elevated TSH or thyroid stimulating hormone, along with low circulating levels of free T in 3,4 are indicative of primary hypothyroidism. So TSH is the most sensitive and useful test for diagnosing and gauging treatment for hypothyroidism. Primary hypothyroidism has a variety of causes. One of the common causes is iatrogenic, which is a low thyroid level that is due to the treatment of hyperthyroidism or treatment of another medication, which one of the side effects of those medications would be decreasing thyroid hormone. The drug that comes to mind there is lithium. Other causes of hypothyroidism could be autoimmune destruction of the thyroid gland, a postpartum thyroid disease, or Hashimoto's thyroiditis, which is a condition in which your immune system actually attacks the thyroid gland, and that results in a chronic inflammation which limits the activity of the thyroid gland, basically making it underactive or hypoactive. So hypothyroidism then is the metabolic state that results from a deficient thyroid hormone level in the body. It's a failure within the thyroid gland. It is actually more common in women than in men, and the characteristic symptoms of hypothyroidism are fatigue or lethargy, sensitivity to cold, which is also referred to as cold intolerance, dry skin, and menstrual disturbances. Those are some of the hallmark things you should be looking for, and then pairing that with the elevated TSH, low T3, T4 levels will help in the confirming of a diagnosis of hypothyroidism. While the book lists a couple of options for treatment of hypothyroidism, it's pretty cut and dry. Thyroid supplement in the form of levothyroxine, which is a synthetic T4 hormone. Its brand name is Synthroid. So the body converts T4 into T3, which is the active thyroid hormone in the body. Supplementation with T3 is almost always not necessary. I've seen a few cases where a patient has been supplemented with T3, but by and large, levothyroxine, the synthetic T4, does a wonderful job treating hypothyroidism. It's important to note that symptom improvement is not immediate when patients are started on treatment for hypothyroidism. It typically takes about 2 weeks to see the full effect of this medication. It's interesting to note too that the effects accumulate over a number of weeks. So yes, you'll get symptom relief, but the full effects kind of accumulate over a number of weeks until you've reached that steady state of the drug for the patient. It's important to reassess TSH and free T4 levels 4 to 6 weeks following any dose change or any change to a different levothyroxine product. And this is why differences in levothyroxine products are important to note. Bioequivalence can be an issue among the various generic levothyroxine products that are available. The variety of available products are not tested against one standard. So The bioequivalence of levothyroxine products is based on the total T4 measurement, not TSH levels. And if you'll remember, TSH levels are sort of the creme de la creme of gauging treatment in hypothyroidism. So bioequivalence is not the same as therapeutic equivalence. Kate, that's a bunch of gobbledygook. What are you trying to get at? What I'm saying is therapeutically, the various products all produce the same type of response, but the extent of that response as measured by the TSH is not identical amongst all the agents. So there is sometimes a push for patients to get the exact same manufacturer of thyroid hormone if they're relatively sensitive to small changes in thyroid hormone availability within the body. So we'll have sometimes where patients will come to the hospital and have to use brand name Synthroid only, and obviously we carry generic levothyroxine in the hospital, so patients will bring in their own supply in those settings and will dispense it to them as their own medication. In patients that are less than 65 years old, it's very common to begin with 50 to 100 micrograms daily. You'll notice that the Synthroid is expressed in micrograms daily. That's a little bit uncommon. Most of the drugs we use are expressed in milligrams. So it's very important to remember that levothyroxine or Synthroid is micrograms. Elderly folks are more commonly started with 25 micrograms daily, and both of these groups of patients will reach a usual maintenance dose of somewhere between 75 to 150 micrograms daily. I've definitely seen higher doses, but 75 to 150 is really the wheelhouse of normal. It's important to educate patients to take their medications at the same time each day, and preferably before any other medications or food, so that they get full absorption of their Synthroid. I once had this cute little lady come into the hospital, and when I was interviewing her about her medications, she told me that she woke up at 4:30 every morning to take her Synthroid, and then she would go back to bed so that when she woke up at 5:30 she could enjoy her coffee, juice, and toast without having to worry about how well her thyroid drug was working. So some patients really take that educational piece to heart. We're going to sort of cruise through then the medications that are referred to as thyroid suppressants, or when you have an overproduction of thyroid hormone. So thyrotoxicosis is an excess of thyroid hormone, and it is most commonly caused by Graves' disease, which is an autoimmune process causing enlargement of the thyroid gland and then overproduction of the thyroid hormones. Toxic nodular goiters, or iodine-induced hyperthyroidism, which is iatrogenic. So that's, even though iodine, people aren't taking it as a drug, table salt has a lot of iodine in it, and so that can sometimes induce a hyperthyroidism. Diagnosis of hyperthyroidism, is commonly based on a low thyroid stimulating hormone and elevated levels of T3 and T4, so just the opposite of hypothyroidism, which is sort of what we would expect. In treating Graves' disease then, or a toxic multinodular goiter, the first line is a radioactive iodine repletion. Secondly, surgical intervention, and lastly, anti-thyroid drugs. Methimazole and propylthiouracil, or PTU, are medications that are considered anti-thyroid drugs. Methimazole is really first line, except in the first trimester of pregnancy. If women are experiencing hyperthyroidism in that state, they're going to want to use PTU. Do I think you'll come across that very often in primary care practice? No, but it's sort of at least worth putting in the very far back part of your brain, really just more for recognition rather than memorization. So anti-thyroid drugs then are used to achieve remission of symptoms, but symptom relapses are often very frequent, which is what makes these medications third line. The way that the medications in the previous slide work is that they work through the diversion of iodine, which then inhibits the synthesis of thyroid hormone. PTU, but not methimazole, also inhibits the conversion of T4 to T3 within the tissue, because if you'll remember, in the peripheral tissues, the removal of iodine converts T4 to the active T3. Methimazole is sort of the preferred agent, however, because it's longer acting and it requires a less frequent dosing schedule. So if a practitioner moves to an anti-thyroid drug, methimazole, also called tapazole, is the one that we will more commonly see. Anti-thyroid drugs will exert their effects such that patients will reach a euthyroid state in about 4 to 8 weeks, but they will begin to have a reduction in their symptoms of hyperthyroidism in about 1 to 2 weeks. Sometimes you'll see patients with hyperthyroidism treated with beta blocking agents like propranolol or atenolol, and that helps control some of the cardiovascular signs and symptoms of hyperthyroidism like palpitations or racing heart. It's important to monitor T3 and T4 levels to gauge the efficacy of whatever pharmacologic treatment the practitioner has decided to employ. Generally, patients are treated for about 12 to 18 months. Once that euthyroid state has been reached, which happens typically in about 6 to 12 months, the drugs can be discontinued to see if a remission has been achieved, knowing that symptom relapse is frequent, but at least it lets you know if you have their hyperthyroidism in remission and they can have a period of drug-free treatment. That's different from hypothyroidism because hypothyroidism requires lifelong therapy. You're never going to achieve a remission. Your body's not all of a sudden going to start making more thyroid hormone. Conversely, though, in hyperthyroidism, it can sort of reset and re-regulate itself to stop the overproduction of thyroid hormone, which is why you're going to want to back off on drug to gauge remission in the hyperthyroid patient. Super quick patient education note for patients that are hyperthyroid. They're going to want to avoid foods and substances that contain iodine, which would be seafood or iodized table salt. So you'll see in this chapter we really focused on hypothyroidism, and I would say that as a primary care practitioner, that's where the focus of your practice will be in dealing with thyroid diseases. A lot of hyperthyroid cases are commonly referred to an endocrinologist because of the hierarchy and the options in treatment and the close monitoring of those patients. So I think it's probably safe to say that from my standpoint for a midterm exam, hypothyroidism is where I would focus the attention. I wanted to include hyperthyroidism though, for fear that I would leave something out that would lead you astray in the future. So we did the quick overview of hyperthyroidism so we could cross all our T's and dot all our I's. Thanks much.